Good afternoon. I'd like to welcome you all here. I'm Dr. Lou Baxter. I'm from the Addiction Medicine Foundation, and today we will address the urgent need for trained physicians in the field of addiction medicine, a newly recognized field that heralds the beginning of integrated physician education from the first day of medical school to the last day of residency training. Across all congressional districts, citizens are asking their leaders to address the horrendous toll opiate, alcohol, and other drug use is taking on families and communities. An essential response will be building a trained workforce of addiction physician experts, which is critical in addressing the current opiate epidemic and our endemic alcohol, nicotine, and other licit and illicit substance use. Trained physicians will save lives, reduce taxpayer costs, and improve the health of patients, families, and our communities. Actually, will affect the health of our nation. I wish to thank the the co-sponsors of this briefing. We have the Honorable Hal Roberts with us today. The co-hosts are the Congressional Prescription Drug Abuse Caucus, the Congressional Addiction Treatment and Recovery Caucus, and the Bipartisan Heroin Task Force. And we'd like to acknowledge their staff that is here also today. Here in the District of Columbia, like so many areas of the United States, we have a great unmet need for trained and qualified physicians who can address the prevention and treatment in underserved populations. At Howard College of Medicine, we have an accredited addiction medicine fellowship with physicians that are eager to enroll. I have with me Dr. Robert Taylor and Dr. Denise Scott. Could you put your hands up? Thank you. Yet, we have people that have been applying. We had 8 very well qualified in 2016. We had 11 this past year, yet we have no budget resources for our first fellow. All of us believe we are entering a new era, and today's briefing will elaborate on this even more. We need your help. Dr. Kevin Coons, a national leader in the field of addiction medicine and the Executive Vice President of the Addiction Medicine Foundation, will now give a 3-minute overview of the current status of physician training in addiction medicine. Dr. Coons.
Thank you very much, Lou, and welcome everyone. I particularly want to welcome Congressman Hal Rogers, who has been a leader in the Prescription Drug Caucus and is leading in the state of Kentucky, where there's a fellowship and much work to address this national problem, a model program. Congressman Rogers, would you like to say a few words?
Well, thank you very much for allowing me to say a couple of words. I'll be brief because you've got such a great panoply of speakers. I don't want to be in the way, but my co-chair, Stephen Lynch, and I welcome you from our caucus, and we wish you well. This, what CDC calls an epidemic, I choose to call a catastrophe. This problem continues to grow in intensity and in volume, reaching so many families in our country. We've got a lot of people to thank for putting this together. It's been quite a collaborative effort, thanks to the Addiction Medicine Foundation for bringing together this top-notch panel, and to all 3 addiction-related caucuses in the House. My Prescription Drug Abuse Caucus, the Addiction Treatment and Recovery Caucus, and the Bipartisan Heroin Task Force. I want to particularly welcome Drs. Volkov and Koob from NIH. Thank them for being here and for the work that they continue to do. I've enjoyed working with both of these individuals, plus a lot many more, on addiction issues over the years. And I'm grateful that you've taken the time to be with us today. Addiction has taken our country by storm in recent years. When I first became aware of the epidemic roughly 20 years ago in my district, which was ground zero, I admittedly saw enforcement as the solution. I quickly learned from our work in Kentucky that anything short of a holistic approach just wouldn't cut it. We need enforcement, we need prevention, and we need treatment, acting in concert to tackle the full scope of the problem. With the help of experts across the country, we've made tremendous progress in shining a light on this nationwide epidemic, revealing the wounds it leaves behind and what we need to fight back. Thanks in part to the work of our panelists, addiction medicine is now its own distinct subspecialty. But it's been a tremendous challenge to train enough addiction specialists, attract them to the communities most in need, and retain the addiction medicine workforce. Our panel today will update us on the latest prevention and treatment research and demonstrate the supreme importance of the addiction medicine workforce. I'll not be able to spend the entire time with you today, but I want to know that we sincerely appreciate your work and hope that you can translate lessons learned to progress going forward. So thank all of you for being here. Thanks for your dedication to this problem and the national effort that we have all undertaken together to bring some relief from this catastrophe in which we find ourselves across the country. Thank you for being here. Good luck. God bless.
Thank you, Congressman Rogers, for your work and your comments. Before I start, I'd like to briefly acknowledge from the American Society of Addiction Medicine, Penny Mills, our sister organization that has been working at this since 1954. So these are great days for all of us that we have such an opportunity to speak. America is now experiencing the worst epidemic since the 1918 influenza global pandemic, the deadliest natural disaster in America's history. Opioids are now a killer worse than HIV at its peak, and alcohol, nicotine, and other drugs have an unrelenting toll that brings total drug deaths in the United States to over 600,000 a year, about 1 in 4 deaths. The public's plea to healthcare providers and to governors and congressmen and congresswomen and to each of us in this room is, who can help me? Individuals, families, communities also ask us and our congressional representatives, are you doing everything you can? We all say we are trying and doing our best. Here is an essential piece of the solution that we have been missing, and yet it is now available and can be scaled up: the training of physicians in the field of addiction medicine. Physician training in a medical subspecialty is inexpensive and effective. For instance, as in hospice, sports medicine, and cardiology, training a subspecialist physician in addiction medicine costs just over $100,000. These physicians are desperately needed in all states, and some states have already found ways to pay for some level of support for physician training programs. Both state and federal assistance is needed. How do you spend $1 billion to fight an epidemic when you don't have a workforce? Well, let me work through where we are today in addiction medicine. Our bottom line in the left lower corner is to provide prevention and care at the level of the patient and the family and the community. To do that, we need what's in the middle, an expanded addiction medicine workforce. Currently, about 3,500 physicians working part-time. Our studies show that we need 7,500 full-time physicians in this subspecialty by 2025. Until now, we've had difficulty getting that because addiction and addiction medicine weren't recognized by the family of medicine as important. And that changed in 2016 when the American Board of Medical Specialties and the Accreditation Council for Graduate Education said, we're on board. This is something that physicians have a responsibility to. Maybe we've been asleep at the wheel. Maybe we drove the car into the crowd, but now we're going to stand up and do the right thing. So what's it look like to train someone in addiction medicine? Many people think what you learn in medical school is what you become as a physician. It's simply not true. Medical school is the beginning. It's the last day of medical school that you actually get your MD degree. And then you go on to a residency, let's say family medicine or internal medicine, pediatrics, OBGYN, for 3 to 4 years, and that's where you really learn to be a doctor. It's the true apprentice trade where you learn not just the book learning, but the real learning. And you ask, who teaches in those residencies? Who teaches addiction medicine there? Who teaches in the medical school? What role models do they have? What mentors do they have? Across medicine and in addiction medicine, those are physicians trained in fellowships. The Addiction Medicine Fellowship is 1 year, and they become not only clinical experts, but faculty, teachers, researchers, and change agents. Then all physicians must do maintenance of certification, and that is very deliberate these days as compared to just get us a few credits every year. So this is something physicians can keep up on. Fellowships drive the care of patients with addiction and the prevention of addiction, which is even more important than treatment because, as you know, we will never treat our way or incarcerate our way or bury our way out of these epidemics. We've got to get prevention and early intervention online. So fellowships, they produce clinical experts, they produce faculty, researchers, and change agents, and we need these across our country and in every state. When an addiction medicine fellowship exists, it becomes a center of excellence in that community and state. Fellowship training drives knowledge and practice across medicine and healthcare. It involves all aspects of the community. Teaching reaches down across disciplines. This is an interdisciplinary field. Our current status is we have 45 programs that we've accredited awaiting ACGME accreditation early next year. These programs could all be expanded. Most only have one fellow being trained. Some have a program with no funding for fellow, as Dr. Baxter mentioned at Howard. We are particularly interested in underserved areas. So we're on goal for 125 programs, but we can't do this and we can't expand those slots without help. This is a new field. It's hard to butt into medicine and say, give me money for training. So again, if there's $1 billion and no workforce, what are we really going to do? So today, I think you'll be hearing more about the science and about the work that is being done at not just in the science, but and so appreciative of the work that Dr. Koob and Dr. Volkow have done at NIAAA and NIDA, and we'll hear from speakers that really are on the ground floor of treating this epidemic. But without physicians that are trained, this won't happen. This is a war. It's time to scale up our physicians that are trained in addiction medicine. Thank you.
Thank you, Dr. Coons. I'm now pleased to introduce Dr. George Koob. He's the director of National Institute on Alcohol Abuse and Alcoholism. I'd like to thank you so much, George, for coming and presenting for us today.
Well, thank you, Luke. Thank you, Congressman Rogers, for joining us. And I'm here to tell you about the elephant in the room, right? And that is basically alcohol. So the mission of the National Institute on Alcohol Abuse and Alcoholism is basically to generate and disseminate fundamental knowledge about the effects of alcohol on health and well-being, and apply that knowledge to improve the diagnosis, prevention, and treatment of alcohol-related problems, including alcohol use disorder across the lifespan. Our priorities are mechanisms of alcohol's action, diagnosis and tracking of alcohol misuse and alcohol use disorders, prevention and treatment of alcohol misuse, alcohol use disorders, and co-occurring conditions. And we'd like to enhance the public health impact of our NIAAA-supported research. We are the largest funder of alcohol research in the world. I think sometimes it's missed in the big picture, but the cost and scope of alcohol-related problems is prodigious in our country. As I often say, people have heard me say this before, if you go into any emergency room on a Friday or Saturday night in San Diego County, you're going to find half the people there are due to alcohol or drugs. We lose approximately 90,000 people a year annually from alcohol-related causes. It's the third leading preventable cause of death in the United States. And if that's not enough, I think you really need to realize that now alcohol is the cause of about 50% of liver toxicity in this country. And we're seeing younger and younger people with severe alcoholic liver disease. And there's been a fairly dramatic increase in emergency room department visits and hospitalizations related to alcohol in the last 10 years. We call this extreme binge drinking. These are the individuals who are drinking 10, 15 drinks in an evening. And on college campuses, some of them drinking to blackout as a goal. It's hard to believe. And the age group that this is most predominant in, believe it or not, is 20 to 30-year-olds and over 60-year-olds. So addiction is a chronic brain disease. I'm just going to speak a little bit to this very quickly, but decades of research shows that addiction is a chronic brain disease. Nora Volkoff has led the way with human imaging studies to actually demonstrate in the human brain that it is a brain disease. Frequently co-occurs with mental health conditions, other mental health conditions, and it has many features in common with other medical conditions, diabetes, hypertension, and obesity. It's chronic, has the potential for recurrence and recovery. It's influenced by genetic, epigenetic, developmental, and environmental factors, requires a comprehensive approach to treatment. Nora and I have long studied the neurocircuitry of addiction. We've come up with a framework that can identify the different stages of the addiction process, the different neural circuits in the brain that are affected, the different chemicals that are affected in those neural circuits. So we know a lot, but we need to get that out into the medical community as evidence for prevention, diagnosis, and treatment. It's really critical. So let me just review with you very, very quickly some of the things we do know. What about preventing and treating alcohol use disorder? Well, we have a number of approaches that actually really work. One of them is screening, brief intervention, referral to treatment. If your physician asks you how much you drink when you go in for a physical and how much your friends drink, that is a brief intervention. And as I always say, you're going to lie. You're going to tell them some fib. But on the way home, you start thinking about it. How much do I really drink? Is it really healthy what I'm drinking? This guy in a white lab coat has asked me these questions. There are professionally led behavioral interventions. There's FDA-approved medications. There's a mutual support group, such as Alcoholics Anonymous. We know, as I just mentioned, that screening is an effective prevention strategy. Alcohol screening in primary care reduces alcohol misuse among adults. It's recommended by the U.S. Preventive Services Task Force. There's mounting evidence that screening is effective for preventing and reducing youth alcohol misuse. And one of the highest ranking preventive services, it's one of the highest ranking preventive services among 25 effective services. We have a number of publications on this, helping patients who drink too much, a clinician's guide, and a 2-question youth alcohol screener, which I just mentioned. And these documents can help clinicians identify alcohol misuse in adults and youth, respectively. And prevention saves money. If I haven't convinced you from the human perspective, from the cost to society, even financially, we know that these behavioral prevention approaches actually work. One of the most effective is a good behavior game, actually, and you can see the benefits per dollar cost outlined in this slide. We also have effective professionally led behavioral interventions, cognitive behavioral therapy. This changes the thought processes that lead to alcohol misuse and develops skills and helps develop skills to cope with situations that trigger problem drinking. Motivational enhancement therapy. This enhances your motivation to change drinking behavior by aligning changes in behavior with life goals. Community reinforcement. Facilitate changes in a person's life to make abstinence more rewarding than drinking. Marital and family counseling incorporates family into treatment to help repair and improve family relationships. All of these combined actually form the basis of many well-validated and certified treatment programs that are available in the United States. We in the alcohol field have 3 FDA-approved medications. I always challenge physicians to actually see if they can name these 3 medications, and I'm not sure how many primary care docs can name these medications. We have disulfiram antabuse. It basically makes you sick if you drink. Works really well if you take it, but you have to take it. We have naltrexone, which blocks the reinforcing effects of alcohol and actually works and will decrease heavy drinking. And we have a camprosate, a drug that actually helps people who have decided they're going to abstain or cut back on their drinking significantly and are engaged. It helps them along the way by reducing some of the negative symptoms that evolve as abstinence progresses. But here's the really main point I want to make is that I've just outlined for you effective behavioral treatments that range from counseling to brief interventions to all the way to medications that can help you along the way. But less than 10% of individuals with an alcohol use disorder get any treatment in this country, okay? And if you want to talk about depression, about 60 to 70% of individuals with a major depressive episode get some kind of treatment. And less than 4% of individuals get an FDA-approved medication to help them along the way. Individuals with alcohol use disorder more often seek primary care for an alcohol-related medical problem than for the alcohol use disorder itself. And again, I want to emphasize the fact that we're not treating alcohol use disorder is costing us untold quadrillions of dollars in medical costs, everything from heart disease to cancer facilitation to the big one is alcoholic liver disease. So we are in the process of developing a new product to help individuals navigate through the treatment system in the United States and find evidence-based treatment. And we're working in collaboration with a number of other government agencies to affect this. I just want to wrap up by pointing out to you, this is a slide that Nora and I put together with the help of Aaron White in my office, but there has been this dramatic increase in opioid hospitalizations and overdoses over the last 10 years. But there has also been a dramatic increase, an equivalent increase in alcohol-related opioid overdoses and hospitalizations. And opioid deaths follow the same pattern and the same lines. And so alcohol is in there. We think this is actually an underestimation. And, you know, just to give you a little bit of quick pharmacology, 2 plus 2 equals 5 when you combine opiates with alcohol. What that means is that it's not just additive, it's potentiating its effects. You can die of respiratory depression much more quickly and at a much lower dose if you're taking opiates with alcohol. Some of you may remember Sanjay Gupta's interview with Bill Clinton, where a young man was lost in a related family to this exact issue, and this was about 5 years ago. So how do we grow the addiction medicine workforce? How do we see it at IEEE? Well, many providers do not perform screening. They're not aware of evidence-based treatments or where to refer people. A study of 54 primary care clinics found that 88% had no policies or requirements to ask patients about alcohol use, and those with policies had no consistent evidence-based methods for screening or referral. Our goal is to improve physician training in substance use prevention and treatment at all levels, from undergraduate and graduate medical education through residency, fellowship, and beyond. We would like to integrate prevention, early intervention, and treatment into routine medical care. We think that the American Board Foundation and what Dr. Kuntz was talking about is a great step in the right direction, and NIAAA has been very, very supportive, and we will continue to be supportive of that program. But we think that more can be done. We would like to see more integration of addiction medicine into medical education. Nora will speak to pain management and the interaction with opiates, but I think all of these are related. We gave an IEEE grant to SUNY Buffalo to translate addiction into clinical practice in collaboration with the American Board of Addiction Medicine. It paved the way for integrating addiction medicine into postgraduate medical education at 37 academic medical centers. It provided a model for residency training in addiction medicine, laid the foundation for recognizing addiction medicine as a subspecialty for the American Board of Medical Specialties, which you've already heard about. So NIAAA, NIDA, and other federal agencies have engaged with the White House on a national effort to grow an addiction medicine workforce. So our goals are the same as Kevin Kuntz's goals, same as Nora Volkoff's goals. We want to identify medical school curriculum needs and enhance addiction medicine questions on medical board exams. And this is a nut that has yet to be cracked, but this is one of the further goals that I'm very dedicated to. And I know that some addiction medicine is taught in medical schools, but I also know that we can do better. So thank you very much.
Thank you so much, Dr. Koo, for your presentation and for all of the tireless work that you have been doing in this regard. Our next speaker is Dr. Nora Volkoff. She's the Director of National Institute on Drug Abuse. Thank you so much for coming.
Thanks very much. Good afternoon. Thanks very much for giving me the opportunity to be here, Dr. Baxter and Dr. Kunz, and for your efforts actually in bringing addiction treatment into the healthcare system. And I'm going to actually be addressing specifically, not addiction in general, but the opioid crisis. And I do want to actually recognize the leadership of Congressman Hal Rogers, because I think that single-handedly he has been able to energize the interest and the recognition in the country of the catastrophe it is, whether we call it an epidemic or a catastrophe. The reality is that it's actually we're losing one American at least every 20 minutes to an opioid drug. And this has actually not, we have not been able to decrease it, and it continues to increase. So how bad is it? And here you have it, how bad it is. Actually, this reflects the maps of the United States, indicating in different colors the number of individuals that died from an overdose per 100,000 inhabitants. And you can see that in 1999, in red, which is the areas, it's the color scale, so the areas of the country that had the highest rates of fatalities was actually limited to 2 regions. One of them is in the middle of Appalachia. And as Congressman Hal Rogers said, that was the cradle of the epidemic. That's where this actually started to be first noticed and occur. And the other one is in New Mexico. Now, the numbers actually, as I say, are reflected by 100,000. And in 1999, the red was basically for deaths between 20 and 23 per 100,000. In 2015, not only have we basically covered the whole United States of states that have very, very high rates of overdose fatalities, but we have had to move the threshold for where we depict in red, because there are some states that have actually more than 35 overdose fatalities per 100,000. So it actually has expanded itself in different fields. We still see as the epicenter of the whole epidemic the Appalachian region, but we also see the New Mexico, Arizona area. And what you don't see very clearly in 2015, but you're going to be starting to see it in 2016 and 2017, is the Northeast, where actually the emergence of synthetic opioids has in some instances more than doubled the fatalities in a single year. So these are the numbers from the CDC in 2015, and the first numbers for 2016, which were estimates, is not the official ones, but they are actually quite accurately, were released on September 2nd in the New York Times, indicating that from 2015 to 2016, we have seen a 22% increase in fatalities from overdoses. And that gets you an idea of the catastrophe in which we are now. So right now, from overdoses, we have 64,000 Americans in 2016 that die from an overdose. Now, those deaths do not include other causes of death associated with heroin or synthetic opioids or prescription opioids that actually bring these numbers higher. As we're going forward as a nation, we have become very, very aware that the opioid crisis was initiated because of overprescription of medications and complacency of physicians that led to the massive prescriptions of pills that then were diverted, abused, and resulted in addiction and overdoses. We also became aware that as physicians, we have been misled into believing that if you have pain, you will not become addicted to your opioids medications, to recognize that patients who were being treated also became addicted, and also some of them were ending up in an emergency department or dying from an overdose. So this is the new data from the September 2nd article that I mentioned you, which actually to your left shows that 64,000 overdose deaths, and I was mentioned earlier, this is surpassing by significant numbers the peak of the HIV epidemic. And the slide to the right, the figure to the right, illustrates the nature of the problem. We basically, as people became addicted to prescription opioids, and as we very aggressively in the healthcare system tried to decrease the number of prescriptions given to individuals, and it became harder to reach those drugs, individuals that became addicted to their prescription opioids, then some of them started to use heroin because it was more accessible and less expensive. And at the meantime, heroin entry into the country increased significantly along with its purity, and its cost went down. At the same time, chemists out there started to develop new synthetic opioids that can be from 50 to close to 1,000 times more potent than heroin, which actually has raised the risk of taking these drugs. And most notable of all of them has been, in terms of frequency, fentanyl, but there are other synthetics even more potent, like carfentanil, for which the overdose occurs with a very, very small amount. So where are we in this crisis? Well, on the one hand, what we've come to realize is that we do have medications that can help actually prevent the overdoses, and it can help prevent drug taking in individuals addicted to them. We have 3 different classes of drugs. All of them are targeting the mu-opioid system, which is the receptor that is activated by heroin, by fentanyl, and by prescription opioids. All of them target it, but they target it in different ways. And in that mechanism, on the way that the medications target the receptors, is why they can be so therapeutically beneficial and why they can help you prevent you from overdosing. The oldest medication is methadone, and we refer to it as a full agonist because methadone binds to the mu-opioid receptor and produces full effect. And you can use it therapeutically safely because methadone gets into your brain very slowly. And in order for a drug to produce a very highly reinforcing, high and addictive component, it has to enter the brain very rapidly. But by occupying this receptor, it prevents the craving and the withdrawal in people that are addicted to heroin or other synthetic opioids or prescription opioids. The second one is buprenorphine, and we refer to it as partial agonist because even if it binds to all of the mu-opioid receptors in the brain, it will never be able to produce the effect in the same intracellular effect or behavioral effect. It's going to be very, very blunted, and that's why it's partial. And finally, we have an antagonist, naltrexone, which actually has been developed in an extended formulations that allows you to inject it every 1 month. It basically binds to that receptor, but it has no effect. And so what it does, it basically occupies that receptor so that when a person is exposed to heroin, heroin cannot do anything because that receptor is occupied. And these medications, they have advantages and disadvantages, and certain patients respond better to one than to the other. But regardless, all of them have been shown to decrease opioid use, opioid-related overdoses, criminal activity, infectious disease transmission, to increase social functioning, to increase retention in treatment, to improve neonatal abstinence syndrome outcomes. So they are very effective. And yet they are being massively underutilized. Now, why are they massively underutilized? I can say 2 things that jump up immediately. One of them is their stigma, and lack understanding about the effects, the way that these medications work. And the other is lack of infrastructure. That is to say, there are not sufficient providers that can actually be able to take care of individuals that would benefit from this treatment. And I must say that with the parity law, now it is illegal not to treat people that are addicted with an opioid use disorder with medications that are actually shown to be effective. So how are we doing as a country? What is our pulse on how we are treating people with an opioid use disorder? where actually it is abysmal. And that's what you see there on the opioid use disorder cascade of care in the United States, and then highlighting why it is urgent that we train more physicians in addiction medicine. So you see in blue where we are, and it refers to those that have severe opioid use disorder, and then those that are diagnosed in blue, and we're doing okay. So it's approximately 2.5 million individuals with an opioid use disorder. 1.5 million are diagnosed. How many of them are engaging in care? 600,000. How many of them are initiated on medication? 300,000. How many are retained for more than 6 months? I would say that it's less than 2%. And how many of them are in continuous abstinence? I would say that 1.5%. That is the cascade of care. Again, that challenge, so how do we change it? And we change it by actively engaging the healthcare system into addressing it, because they are in a unique position. Individuals with an opioid use disorder are going to be ending up in the healthcare system for a multiplicity of reasons, including overdoses. So this is just to illustrate in terms of the treatment programs that we currently have to address specialty of individuals with a substance use disorder. Also that indicating that even in those specialized treatment programs, we do not have sufficient actually patients that are being treated with medications. The most recent statistic, which actually was released by SAMHSA, actually identified that less than 24% of individuals with an opioid use disorder receive any type of treatment. And that, again, highlights the need to expand access and for treatment for our extraordinary severe disease with a very high risk of fatality. So we know that indeed in intervening actually into the healthcare system, engaging the healthcare system is probably our strongest infrastructure that we currently have across all of the states in the United States. And so if we engage, and this is what NIDA has been doing in terms of helping develop models of care that will be shown to be effective, that take advantage of the healthcare system. And that actually, of course, requires that we train not just physicians, but also nurses in the management of these patients. And this just illustrates how in the federally qualified health centers, this is a study that was done in Connecticut that shows that at 6 months, they were able to, when physicians in a federally qualified health center initiated buprenorphine, were engaged with it, which is not traditionally what is done or has been done, they are able to retain these patients as long as specialized treatment programs do when they utilize these medications. So at 12 months, 62% of individuals that were with an opioid use disorder were still in treatment. If you do not provide that treatment, you can guarantee that at 12 months, 95% of them would have relapse. So this is a very effective intervention. The other area where we can actually take an enormous advantage and where the models are being developed is the emergency departments. Actually, patients end up in an emergency department with an overdose, and believe it or not, what do you think happens for the majority of these patients? They are released out into the community. Now, these are patients that just overdose, that are going to be in withdrawal, and what do they go? They go and seek medications. So the risk of overdose is extraordinarily high. So that's one of the things that we are observing, that patients are actually safe from an overdose, and then there is a subsequent overdose. So now there are multiple centers in the United States that are testing a model where you actually initiate the treatment of the person that is there with an overdose with buprenorphine right there. And that very simple intervention significantly improved the outcomes. And here you see the data comparing of initiating buprenorphine in the emergency room versus referring, a significant decline in the use of heroin. And actually, they also show in this particular study that they also prevent readmissions into the emergency room. We're also trying to, again, taking advantage of the tremendous healthcare infrastructure that we have throughout the country, is also engaged not just on primary care physicians, on emergency department, but in specialty physicians, other specialty physicians. And this is just also to indicate what happens when you engage infectious disease clinics, where you are actually likely to be seeing an overrepresentation of patients with opioid use disorder because of HIV, because of hepatitis C. And again, you compare the clinic-based integrated models versus referral for treatment, for the treatment of buprenorphine. And again, I'm going to highlight what was said before. Having fellows that have the specialty of addiction can not only allow them to treat directly the patients themselves, but also to mentor other physicians on how to do it. This is also illustrating the downstream impact. In this case, what this study is showing is a different studies. These integrated models actually not just improve the ability of the patient to be in buprenorphine, but in this study, they actually showed that the outcomes on HIV, whether it was CD4 counts or viremia, were significantly improved when you integrate the treatment. So, and I want to actually just in this slide highlight another aspect. So we do research not just in terms of developing models and implementation to how to actually engage the healthcare system and evaluate the outcomes, because it is the way that as a nation we are going to have to stop this epidemic. That healthcare system needs to get engaged. It's not a choice, we have to do it. So the issue is, how do we do it? And that's what the models that I've been showing it. But there's another element to it, and this is, what is it that in parallel we can do to this implementation and model research and services research that can accelerate doing it? And that is the development of new formulations of medications that will make it easier for a clinician to be able to treat these patients. And as I actually have visited some of the areas that had been affected, most dramatically affected by the epidemic, including the Kentucky, including New Hampshire, including West Virginia, what struck me is the remoteness of these areas. These are rural communities. So the opportunity of actually developing medications that will not require for that particular patient to have to attend a clinic on a daily basis, but because they are extended release, once a month or twice a month would make it much more likely that they will be treated and that they will be compliant with treatment. So this is some examples of the medications that NIDA has helped develop. Extended release, Vivitrol, 1 month, and significantly improving outcomes. And for these medications, for example, there is also data that has been shown to clearly prevent overdoses in individuals that are treated throughout. They actually They were able to completely, there was not a single case of an overdose in individuals that were treated for 18 months. The other one, the Probufin, is a medication that was developed with this, delivers buprenorphine for a 6-month period. And again, opening up the feasibility of being able to treat patients that don't live near a healthcare system. And my last slide, actually, perhaps is not as cutting edge in terms of research and models and science, but it pertains to also one of the things that as a nation we have to do. It's not a question whether we should do it. We have to do it. So how do we do it? Which is training the workforce. And I cannot be understated. And I'm basically certainly, and I highlight completely, and it has been a pleasure to work alongside Dr. George Koob in many initiatives, including how do we create curriculum that can be used in the healthcare system to train them on the screening and interventions for substance use disorders. So we're creating centers of excellence to actually develop that curriculum. But in parallel, as we're addressing the opioid crisis, we also need to recognize that we need to also train our healthcare providers into the proper screening and treatment of individuals suffering from pain. Because if we don't address the pain of those patients, we will continue to have a black market where there will be a need for opioid medications. And it's so ultimately through training and education that we will be able to erase the stigma that surrounds addiction and that interferes in many cases with the proper treatment of those that are suffering and from their families. Thanks very much.
Tremendous. Thank you so much. Our next speaker is Dr. Mason Turner, Director of Outpatient Mental Health and Addiction Medicine, the Permanente Medical Group. He is presenting here today the Kaiser and Permanente model, really the model of health system integration of addiction screening, prevention, and treatment.
Just give me 1 second, I'm sorry. Thank you.
Hey, good afternoon, everyone. And I'd like to start off, as I start off all of my presentations, with a patient story, because that's what grounds me as a physician. It's what I do. But I also think that it brings a real human face to what we all deal with and we're trying to manage every single day. And in fact, as I was preparing for this discussion today, I was trying to figure out what patient story I wanted to tell you all this afternoon. And one came to me, a very tragic story. As I was en route here yesterday, a colleague of mine, who I've known for a long, long time, shared with me the story of her son, who I'll call Ricardo, who is a 28-year-old with a progressive alcohol and opiate addiction. And the opiate addiction had taken many forms: prescription drug abuse, heroin abuse more recently, but had really been progressing to the point that he really couldn't identify any times when he was not using, 24/7. He had had 245 medical contacts within the last 18 months with the ED, with primary care, other parts of our healthcare system, and he lived in a mid-sized area of the country in a town of about 150,000 people. So he was not in a rural area, but not in one of our large urban centers either. In those 245 medical contacts that he had in the last 18 months, not one provider asked him about his addiction, even though all of his admissions to the ED, the vast majority of the calls to his primary care provider's office, were related to alcohol intoxication or his opioid use or other sequelae that had occurred. They would treat his condition and move on, largely because they were not physicians who were not well-meaning, but because they didn't have the knowledge base to know what to do with a very serious problem that was faced in front of them. So finally, about 2 months ago, he admitted that he couldn't manage his life any longer, and he wanted to find some help. He went to the doctors that he knew best, his primary care physician, and then another specialist that he had been seeing, and they both said, "We don't know what to tell you, we don't know what to do, how to do it, or where you should go for any kind of help. Why don't you call your health insurer?" Which is perhaps a reasonable suggestion. And when he did that, his health insurer said, "Well, I can send you to a specialist that's 300 miles away. You can go into a residential program in California, which is about 2,000 miles away. But otherwise, why don't you try going to AA or NA, because maybe they can help you there." And again, keep in mind, this was a young man with a very severe addiction who really needed 360-degree care. He was ultimately too ill to make calls to go to any of those residential programs, and then he overdosed from heroin and died yesterday. And so I tell you that story because Ricardo was not a Kaiser patient, but Ricardo could have been a Kaiser patient 25 years ago. And I think that his story really shows what a healthcare system, what an insurer and a payer, and what we as a country can actually do when we put our minds to it. We have the support, the resources, and everything else that goes into moving forward in terms of treating our patients better and really managing and dealing with this crisis that we find ourselves in at the moment. Again, wonderful talks by Dr. Valka and Dr. Koob this morning about alcohol and about opiates. I think there's much work to be done. There are other addictions that we need to face, but we can all agree that this is a crisis of really epidemic proportions. So I would say I wanted to talk a little bit today about the Kaiser model and what we're doing within Kaiser Permanente. I work in the Kaiser Permanente Northern California region, but we are present throughout the country. We insure about 12 million individuals in the United States, from here in the DC, Maryland, Virginia area, all the way to Hawaii. And our model is very different in the sense that we are a prepaid model that really focuses on primary prevention. We actually get paid the same, whether a patient is sick or whether they're healthy, but we spend a lot less money on the healthy patients, and so we prefer to see our patients be healthy because it's better for them and it's better for us in terms of our model of care. And all of our work that we have done has really been with the idea of primary prevention and trying to prevent deaths and prevent morbidity from addictions and other healthcare conditions. Now, of course, we have a vested interest and really an obligation to support and expand the addiction medicine workforce in particular, because as an integrated care delivery system, our patients will show up wherever they're going to show up in our system. About 1% of our patients enter a full-fledged addiction treatment, and they make those calls, and they come in to our very extensive and comprehensive programs. That leaves somewhere in the neighborhood of 6 to 7% of our patients who don't touch our treatment programs, but they are going to primary care, they're going to chronic pain, they're going to the ER, perhaps they're showing up in the hospital. And so our approach has been to really look at how we engage in screening patients wherever they show up and make sure that our physicians are equipped and understand what they need to do when those patients show up. So that if a patient like Ricardo comes into one of our offices, that doctor, who's maybe not trained in addictions, but has an interest in a special interest in making sure that his patient is actually treated well, will know what to do and what to say to that patient. Now, we've actually spent a lot of work over the last 5 years looking at how we can engage in primary prevention for addictive disease. And that has been a really important and a very difficult piece of work. So now if you're a Kaiser Permanente member in Northern or Southern California, at least once a year, if you come in to see any doctor in your primary care provider's office, a nurse practitioner, a medical assistant, you come in for any reason at all, once a year, you'll be asked questions to find out how much alcohol you drink. And if you drink too much alcohol, you will be counseled that it's too much and that you should cut down. Now, I love Dr. Koob's statement about, well, you know what, those patients may not exactly admit to the fact that they're drinking too much, but we'll tell them what the safe limits are and that they can at least think about it on their way home that day. So that's been very important because we can identify patients who are in need of extra screening and referrals, and we can get those patients then typically within the same visit or at least within 24 or 48 hours into one of our addiction treatment programs. Anywhere in our state of California, here in the Mid-Atlantic region, and we're working on this in the rest of our regions, primary care can pick up a phone, engage in a video visit or a phone call with an addictions expert, and then get the patient the care that he or she needs. We've also integrated screening and primary prevention into OBGYN. So if you're pregnant, at least one time during the course of your pregnancy, usually within the first trimester, you'll be asked a series of questions about whether you use any substance at all. And if you say, I had one drink in the last month, you'll be referred to a specialist who will actually assess whether you're at risk for an alcohol use disorder or a substance use disorder and referred for the appropriate treatment. And as a result, we've seen improving health among our neonates that are born, fewer days for neonatal abstinence syndrome, fewer incidences of fetal alcohol syndrome and other issues that come along with substance use during pregnancy. We also are very aggressive about cigarette smoking because we are in California. The state of California would actually like for no one in that state to smoke cigarettes. So we're very much in line with that and have been working on that very aggressively as well. Now, all the primary prevention in the world will not help you if you do not engage the patient and help them to understand really what the issue is and why it's important to them to seek treatment. And so a large part of our work now is to go beyond the screening and the interventions at the point of the primary care visit, but to really help that person understand why he or she should actually enter into treatment and why that's important for them as an individual. And I think, again, a lot of us go into medicine and we go in and we say, we know what to do. We know how to do the screening. We know how to identify those patients who are at risk. And occasionally we forget that the patient has to make the decision to engage in the treatment. So we all have to remember that a patient has to be engaged and understand really what he or she needs out of that encounter in order to move forward in their treatment. And the workforce being trained in addiction medicine is really key to that. Even if it's basic training in motivational enhancement therapy or how to talk to a patient who's addicted, that's actually a piece of it. But really understanding how we integrate addiction medicine treatment into all phases of our medical care program is one of our goals as well, in addition to training specialty physicians who do that as well. We've also assured quality addiction treatment and disease management services. Like many healthcare systems, we have a fully automated electronic health record accessible throughout the nation, our entire program. If I'm a Kaiser member in Northern California, I can walk down the street to the Kaiser clinic here. They'll have my medical information at hand and can treat me appropriately as needed. We also have clear treatment pathways. We have different systems built into our EHRs that allow us to identify patients at risk and to engage in consistent and reliable treatment pathways. And that's led us to a reduction in our use of opioids. About 2 years ago, we engaged in a very specific initiative to reduce the use of opioids in our system. And we actually, Dr. Volkow had a slide that showed the average opioid equivalencies, morphine equivalencies that are being prescribed, somewhere around 200, I think, at least in the slide you showed. In our system, we have been so aggressive at reducing the use of opioids for our patients that we're down to less than 50 morphine equivalents per patient that are prescribed opiates. That is a tremendous accomplishment because we started at 200 or 250. And I think the idea behind that is that it's been engaging the patient, engaging our workforce, and explaining the consequences of addictions in our system of care. And again, this is something that any system of care can do if there's the will behind doing that. I would also add that as part of that work, we've identified treatment pathways for various specialties. We know the needs of opiates out of the ER are different than the needs of opiates out of orthopedics or out of primary care. And so with that in mind, we've engaged our specialists in trying to understand how they prescribe and to make simple interventions, like if you're prescribing out of the emergency department, a patient needs some Vicodin because they had an injury, give them 5 tablets and make sure they see their primary care doctor in 2 days rather than 30 or 45 tablets and just say, well, follow up if you need to follow up. Those kinds of interventions have really been very simple, and they've resulted in a vast reduction in the use of our opioids in our system. And then finally, we're engaging in a great deal of research to understand how we can deliver addiction care in our system, and that includes looking at how we train our addiction medicine physicians. We have probably about 30 to 35 addiction specialists within Kaiser Permanente, Northern California, ensuring a little bit over 4 million people. And that's a density of addiction medicine providers that a lot of organizations don't enjoy. We have ready access to our addiction medicine providers, and we're able to engage in different initiatives because of that number of providers that really put the care of those patients who need it into specialists' hands, and then train others who will be encountering those patients in their daily work lives. That has been difficult, actually. We have a fellowship program that is just coming up and running that Dr. Coons has been very instrumental in helping us with. And I think as we begin to turn out more addiction medicine physicians within our own system, we'll see the care of our patients, the penetration of patients getting buprenorphine, getting methadone, other medication-assisted treatments will continue to go up, and we will see lives saved as a result of that. So a lot of our research has been in how we do that, how we implement those changes, and we are making a great deal of progress. But we also come out and we educate people like yourselves and providers to say, you know, yes, Kaiser Permanente is a very different model than most of you, if you're not Kaiser members, have had a chance to interact with. But this can really be done in any system of care if there's the will and there's the expertise and the knowledge and the interest in moving this forward. And we have no choice at this point. As you see, this is an epidemic of unmatched proportions, and I'm glad to hear Dr. Koob saying, you know, alcohol is something we can't forget about. That results in a great deal of morbidity and mortality for our patients, and we must focus on this for the public health of our nation. So thank you for your time today and for coming.
Thank you so much, Dr. Turner. So we've heard the science. We've heard how it can actually be implemented in systems. And now we need to understand how this training comes about. Our next speaker is Dr. Anna Lemke. She's the director of the Stanford University Addiction Medicine Fellowship, and she's president of our Addiction Medicine Fellowship Directors Association.
I'm very honored to be here today to speak with all of you. I'm going to make 3 simple points, but I hope are simple. First of all, I want to make the point that physicians on average know very little about addiction medicine and are harming patients out of ignorance. Second, training physicians in addiction medicine will improve patient care. And third, that one of the best ways to educate physicians in addiction medicine is to promote addiction medicine fellowships. So in terms of the first point, physicians on average know little about addiction medicine and are harming patients out of ignorance. Just this month, I got a call from a colleague of mine, a pain medicine specialist who works for a large integrated healthcare center in Northern California, because she wanted my advice. She had been tasked by her institution to identify all patients in the system taking Opana ER to help them get down and off of this drug. Now, as you know, Opana ER is an opioid painkiller. It was at the center of the HIV outbreak in Indiana in the spring of 2015. And due to its high risk of misuse and addiction, it was pulled from the market in July 2017 at the recommendation of the FDA. My colleague was disturbed by the information she obtained regarding one particular patient, a 28-year-old man with chronic pain on the following medications. And I just want to emphasize this is this month. This isn't a case from 1990. This isn't a case from 2001. This is a case from this month. So this is an otherwise healthy young man on Opana ER, 40 milligrams twice a day, Dilaudid 30 milligrams once a day, oxycodone 60 milligrams once a day, phenobarbital 65 milligrams once a day, Valium 20 milligrams once a day, Restoril 30 milligrams once a day, and wait for it, Xanax 8 milligrams once a day. Nope. So this young, otherwise healthy patient with no organic pathology to explain his pain was being prescribed 450 morphine milligram equivalents daily of opioids. By the way, 4 times as much as the average heroin-addicted person consumes in a day. In combination with powerful sedative hypnotics, phenobarbital, and 3 different benzodiazepines, also at extraordinarily high doses. His immediate problem was risk of death due to accidental overdose. His longer-term problem was iatrogenic or doctor-caused addiction. So I said to my colleague, wow, do you know anything about the doctor who's prescribing this? And she said, you know, she's a primary care physician. She's really nice. She's really caring. She inherited him from an older doctor who retired and just continued the same meds. Ignorance of addiction medicine, who's at risk, how the brain changes in response to drug exposure, how to treat patients who have become addicted, explains in part how a, quote, really nice, really caring physician could continue to prescribe medications in this way to this patient. Okay, point number 2, training physicians in addiction medicine will improve patient care. Instead of quoting the many studies showing how addiction medicine training improves treatment and reduces implicit negative bias toward patients with addiction, I will offer up my own journey as evidence of where we've been and where we need to go. I was trained at one of the best medical schools in the country. I did my psychiatry and apprenticeship period after medical school at the same outstanding medical school. I completed a fellowship after residency in mood disorders, also at the same esteemed institution where I continue to practice today. Yet when I completed my training in 2001, including specialized training in how to treat mental illness, I knew nothing about how to screen or intervene for substance use problems. Indeed, I shunned those patients, considering their problems outside the scope of my practice and even outside the scope of medical treatment. Addiction, I believed, was a social and moral problem, not a medical one. Now, you might conclude that I must have been a particularly poor student, which is always a possibility. But in fact, there was little or no training in addiction medicine in my medical school outside of the CAGE questionnaire, a 4-question survey designed to detect alcohol problems. I seldom used the CAGE questions, and when I did, I desperately hoped my patients screened negative because I wouldn't have known what to do with an alcohol problem if I found one. Even in my psychiatry residency, training in addiction medicine was available to those who sought it out, but virtually no one did, and it was not mandatory, so when it came to substance use, I practiced psychiatry using the same policy my faculty mentors did: don't ask, don't tell. In my first year of independent practice, I was treating a young woman for depression with a standard antidepressant and psychotherapy. Almost every time she came in, she was drowsy, and sometimes she would nod off in mid-sentence. She said it was a side effect of the antidepressant, and I considered writing up a case report of extreme sedation in response to this particular antidepressant. Then about 6 months into our treatment, her brother, to whom I had never previously spoken, called to let me know that she had been in a rollover car accident. She was using, he said. Using what? I asked. There was a pause while he took this in and then said with understandable frustration, heroin, of course. Didn't you know? What have you been treating her for? Indeed, what had I been treating her for? We had talked about her childhood, every conversation she'd ever had with her mother, her sex life, her spending. No taboo subject was left unturned except substance use. I had not once asked her about drugs or alcohol. And even if I had asked and she had denied, I should have known the telltale sign of nodding off, a way of falling asleep midstream for seconds or minutes at a time that is characteristic of opioid use. I decided in that moment to learn more about addiction medicine to avoid making that kind of mistake in the future, but I had to cobble the knowledge together piecemeal here and there, taking years to learn something I should have learned in my training. My retroactive education changed the way I practice, and I discovered I loved the work because patients got better, which they weren't doing when I was ignoring their substance use problems. How can we make sure that every physician in training graduates with a working understanding of how to screen and intervene for substance use problems? One of the best ways to do this is to promote addiction medicine fellowships. Addiction medicine fellowships produce a cadre of advanced practitioners across diverse specialties who will not only provide the needed quality specialty care, but also inspire medical students, train residents, and act as change agents to influence practice, education, and policy. Medical students are inspired to learn when they have teachers who are passionate about and expert in what they do. The only way to produce expert teachers for the next generation of medical students is to have specialty training in addiction medicine in the form of addiction medicine fellowships. Following medical school, residency is a time to learn skills directly from more experienced mentors while caring for patients together on the front lines. The expectation is not that every resident will go on to become an addiction medicine specialist, but every resident should have a basic understanding of how to prevent, screen, intervene, and when necessary, refer for substance use problems. Addiction medicine fellowships will produce the faculty mentors needed to teach residents these skills. As physicians of all specialties come into contact daily with patients who struggle with unhealthy substance use or have addiction medicine specialists will be able to provide medical expert consultation. In order to provide the care that is needed to help patients with substance use problems, we also need policy advocates, individuals who, for example, will fight to enforce the Mental Health Parity and Addictions Equity Act of 2008 and demonstrate the critical importance of insurance coverage for prevention, treatment, and disease management services. Addiction medicine fellowships will create physicians with the passion and conviction to be leaders for education and policy reform. We now have 48 addiction medicine fellowships. 45 are located in 25 U.S. states and 3 are in Canadian provinces. Our goal is 125 programs by 2025, with each program training 2 to 3 fellows per year. One of the greatest obstacles facing current programs and to creating new ones is sufficient financial resources. We could use your help, and I have a couple of ideas you might consider. Number 1, existing and emerging fellowships in addiction medicine could be fully funded by federal mandate. There is a precedent for this in geriatrics, whereby geriatric fellowship programs are funded by a line item in the federal budget. This would jumpstart the fellowship development process, helping to build the critically needed addiction medicine workforce. Number 2, addiction medicine fellows could be offered medical school loan forgiveness in exchange for working in underserved addiction-ravaged communities upon graduation from fellowship, a kind of Peace Corps model. We're looking to make changes to the practice of medicine that will last not a year or 2, but 4 generations. To accomplish this, we must revolutionize medical education from the inside out and embrace addiction as a disease in all of its forms, from nicotine, alcohol, and marijuana to prescription and illicit drugs. Addiction medicine fellowships will build the critically needed addiction medicine workforce and promote much-needed inspiration, expertise, and advocacy across the full spectrum of medical training. One final note, to fully address the growing problem of addiction, we must also focus on prevention. A critical part of fellowship training is understanding the causes and correlates of this disease, its risk factors, and effective methods of prevention and early intervention. Addiction medicine fellowships will help to communicate this knowledge broadly across the medical profession. Thank you again for this opportunity to testify and for your leadership in addressing this public health epidemic. Together, I believe we can train a medical workforce to provide the compassion and expertise our patients with substance use problems need and deserve. Thank you.
Once again, I'd like to thank our presenters. Excellent presentation, and I keep learning more and more and more. We have time for some questions now, so if there are any, please take this opportunity. We have the panelists here. Yes.
Penny Mills with the American Society of Addiction Medicine. I want to thank all of the presenters for their comments. Dr. Lemke, I wanted to add one other ask potentially to your list, which is very short term, that staff from the Hill could go back to their representative about. There was $10 million in the 21st Century Research Act for National Health Service Training Act. We can include addiction medicine fellows. That could get included in the 2018 Omnibus Bill and help to move quickly in some of the funding that's being mentioned as needed here. So I would add that as a comment. Thank you.
And I would just respond that it really is a tragedy that we have wonderful programs up and running at wonderful institutions across the country. We have interested physicians who want to do this work, and we cannot fund those learning opportunities. It's just a terrible shame.
Okay, any questions or other comments? Yes, sir.
I would just like also to thank everybody, and on this note of training physicians, we all know, and you have seen this in your friends and in your family, that when someone wants help, find them. They will do anything for help, and they cannot get it. We say, what a tragedy is that? What is spoken of here is when a doctor wants to learn how to be there for that patient, and they can't get training. What a tragedy is that? So we're partners with our patients, and I think the speakers addressed that.
Thank you, Dr. Kuntz. Well, on behalf of the sponsors of today's briefing, I want to extend a special thank you to all of our speakers and for their presentations, and thank all of you for being here. We hope this information will be useful as Congress seeks solutions to the scourges of America's opioid, alcohol, and other substance use disorders, impairing and threatening our society. We have work to do, and some next steps were outlined here today. The Addiction Medicine Foundation will continue its work to build a new physician addiction medicine workforce and export science-based knowledge and practice across all of healthcare. We look forward to working with you to support the training of a new generation of physician experts in the field of addiction medicine. Thank you all once again.